Thank you, Sri. Thank you for the participants for joining us on time. I know that there are more people to join today. You might have been hearing about pain management for the last three sessions, probably. And we might have discussed a lot of scenarios. I've heard a few of them, a lot of scenarios where we discussed patient stories, where you managed pain, and we heard from other folks. Today, we'll be talking a little bit more deeper into the pain management, difficult pain, because all the pains that we see or we have discussed so far, uh, there were always some questions which were unanswered. I'm not telling that this session is going to give you all the answers. Probably this will give you more questions so that we'll go back and start exploring more about pain and its management. Today we have Dr. Rajagopal. He's the director of WHO Collaborating Center. That is the TIPS, under which we are running the current training program. And he's also the founder chairman of Pallium and is currently the chairman emeritus. I am not going to read the entire slide introducing him because most of you might be knowing him. Some of you mentioned in the beginning that you will be waiting to listen from Dr. Rajagopal. And I'll just talk about one thing, that if you have not read the book Walk with the Weary, I strongly recommend you to write to us. We will send the book to you. It is a wonderful book published by Dr. Rajagopal, a lot of stories, which will give you more insight about or something which you can really connect to what you have seen in your own patients. So kindly let us know. We can send across the book Walk with the Weary. Thank you so much, sir, for doing this session with this cohort this time. Thank you so much. So you're muted.
Thank you, Sri and Sri. Hey, hello, everybody. Hi. Hey, mandatory smiles, please. Yeah. Oh my God. All of a sudden, the screen lighted up. Very good. Dr. Das, good to see your smile after a long time.
Yes.
So, friends, very happy to be with you. I know a lot of you as personally, but not everybody. Thank you. It's good to have friends in so many places. So the session is titled Difficult Pain. Okay, concise. Essentially what it means is management of pain that is difficult to treat. I want you all to start with a guesswork. You have now learned about the World Health Organization's the analgesic ladder. Step 1, non-opioids and adjuvants. Step 2, non-opioids and adjuvants and weak opioids. Step 3, non-opioids, adjuvants and strong opioids. Out of the strong opioids, unlike the Western world, we have very limited choices. The majority of institutions in India in step 3 have only morphine and sometimes transdermal fentanyl, which is too expensive for the vast majority of our patients. Most institutions do not have methadone. So for practical purposes, for the vast majority of patients, in step 3 of the ladder, the only medicine that we have is morphine. So friends, suppose you are treating your patients with step 1 and 2 and that's not enough. You go to step 3. What percentage of your patients are likely to get pain relief? With step 3 of the ladder, using morphine, do you think everybody will get pain relief? Or let us take only cancer pain, to keep it simple. Do you think everybody with cancer pain will get pain relief? either speak or put it up on the chart. Jyoti says no. No. Okay. No. Yes. Uh, so, what percentage of patients are likely to get pain relief with step 3, including morphine? The
20%,
second guess. Sorry,
70%.
70%. More
Yes.
than 90% says Jyoti. Pradeep says 60%. Nishant is very pessimistic and says 40 to 50%. Okay, this will come to the percentage yet. But what we are going to talk about is how do we tackle these situations where you are doing everything that you have and still a good number of people do not get adequate pain relief. I'm not saying no pain relief, adequate pain relief. So here are some age-old data. One is from 1995. I'm sorry that I do not have very recent data on this. But according to these two publications, 71 to 76% of patients have good pain relief with the ladder, including morphine. Now, the reason why I could not find recent data is that sometimes just a report is not considered a good evidence. You need comparative studies. You cannot do control studies by denying somebody pain relief. So this study is not a very easy, but this is what we know. So what today we are discussing is how do we tackle the other 25% of patients. Before we jump into the management, let us prepare ourselves. The first step, start by believing the patient. Sometimes this is especially the senior doctors may have this thought, hey, I'm doing everything. Why is he continuing to say not enough pain relief? Maybe it's all hysterical. No, we start by believing the patient. When the patient says, I have pain, the person we assume has pain. Look for correctable factors. Is there something that we have forgotten? The person says he has chest pain. That's not relieved by morphine. It could be pleural effusion. Sometimes bony pains are hard to treat. The best way to treat a bony pain may be a single fractional radiation. If somebody has an obstruction and the tissues are distended, pain relief is not easy without relieving the distension. Like in an abscess that is full and under pressure, or a stomach that is distended. Unless you relieve the gastric distension, pain management may become very difficult. So you look for correctable factors systematically. Every patient, when they say not enough pain, look for correctable factors. And check adherence to treatment. Friends, this morning, I was in our neighboring town of Kollam, and I did a home visit with the local team. The man was a paraplegic with an not uncommon kind of neuropathic pain, even in the paralyzed area. He was given analgesics. He was given 2 medicines. The person was still in pain. So I sat down beside the man and his wife and asked, are you taking these medicines? They said they had a sheepish kind of look on her face. The woman had a sheepish kind of look on her face, and she said, no, we have run out of the medicines. So the nurse standing by, oh, why didn't you call us? The woman is working in the same hospital. Why didn't you call us? And there was something wrong. So I asked to speak to the couple alone. So very obligingly, the nurse and everybody else left. So I said, if you are not taking the tablets, there must be a good reason. Tell me what it is. What is it? And the woman said, I am scared about his kidneys failing. They are associated pain management, painkillers with kidney damage. All that was necessary was to explain. But let me tell you, ladies and gentlemen, this is very important. We will keep on giving medicines, assuming that they are taking the medicines. Remember that only 1/3 of your patients are taking medicines literally the way you want them to. Always do this. Ask the question without looking threatening. If you say, hey, are you taking the medicines? They will say, yes, madam, or yes, sir. And if you find that they are not taking, then you ask, hey, why are you not taking? I'll take it hereafter, sir. They'll be afraid to speak the truth. They may be. So, in an unthreatening way, ask them. Like I said, if you are not taking them, there must be a good reason. Tell me. And it may be just uncontrollable side effects. It may be their fear. So, friends, please try to remember these steps in preparation. Believe the patient about the pain. Look for correctable factors and correct them. And check adherence to treatment in a friendly, non-threatening way. Now, we are ready to review the current management and make an assessment. Review the kind of pain. Review the management. The first and foremost, look for emotional overlay. Please remember, if there's an emotional reason behind the pain, that is not the patient's fault. We can't be dismissive. It's up to us to find the emotional factors and treat them. Is the person anxious about the disease, about incurability, about the children, about death? We'll have to explore anxiety, depression. Is the person anxious about, am I dying? What is it like to die? Will I die in pain? Does the person know what's happening to him or her? If the person wants to know, I have the duty to tell him with compassion. But if the family is blocking it, I have to get the family also on my side and eventually discuss it with him. And are there social issues? This woman who is worried about the kidney and really caring for him very well physically is not having cordial relations with the husband. They are always snapping at each other. And when I asked everybody else to leave and I talked to them, they came out with their problems. Relationship issues are very common between spouses, between the extended family members. So these are things to take care of. Look for emotional overlay, which may have a social background also. Then, is there a role for an intervention, including radiotherapy that I talked about, or a nerve block? Is there a role for just massage or any non-pharmacological measures that you may have talked about as part of pain management, including transcutaneous electrical nerve stimulation? And review the type of pain. Is it nociceptive pain? Is it neuropathic pain? Neuropathic pain which arises from abnormal impulse generation in the nervous system. The person that I saw this morning had very clear neuropathic pain, which is the central type. He had a spinal injury and paraplegia, but at the level of the injury, he has pain which he says of a score of 6 to 8. And he also has pain down the limb, a different kind of person, which is also central neuropathic pain. So once you try to assess the nature of the pain, you are able to treat it adequately. This person had indeed been given a medicine for neuropathic pain, but then it is necessary to get him back on the medicine, titrate it to adequate dose, and then manage it. So, okay, we have gone through the steps in preparation and review. I don't know whether you all have clarity about this. You have no imaging that can assess a neuropathic pain. These are the three most important diagnostic features. The nature of pain, which is burning, shooting, pricking, lancinating, etc. The distribution of the pain, which is neural or dermatomal. In the case of the man I saw, the one type of pain was precisely in the dermatomes which were fractured, T12L1. And the pain low, the rest of the pain was only in the paralyzed area. So pain associated with a nerve or a group of nerves of a certain nature, often with abnormal sensations. The man whom I saw this morning, I told you that in the fractured segment of the fractured T12L1 area, he had allodynia. Everybody is clear about what allodynia is? ALLODYNIA, pain on stimuli that ordinarily do not cause pain, like touch or mild temperature change. So he had all these. His pain, one was a severe pricking kind. The other was what he described as something like something sharp going into his legs. It is in the area of the trauma, and he had allodynia. All of them may not be there. Abnormal sensations take some time to develop, not in the beginning. It's not necessary to have all of these together, but this will be a good guide. We are reviewing, I said, also the right kind of treatment, the treatment that we are giving, which is what I did this morning. Was he taking the medicines? So just imagine you have seen this prescription being given by a doctor. Paracetamol, 500 milligram TAD. What's your response about that? Any comment on the chat box, please? Well, the dose of 650 would depend on the body weight. It has to be at least 12 milligram per kilogram. 12 milligram per kilogram at least. So, Dr. Noble, as you say, it's inadequate. Paracetamol goes in as an analgesic here, Dr. Jyoti. Divya, absolutely. It has to be 4 times a day. Now, Dr. Bhavika very wisely has noted that the second medicine, the Ultraset, also has paracetamol. Be mindful of that. We don't want to cause hepatotoxicity. So if there are other paracetamol combined drugs, they'll be in very small quantities. Ultraset has a homeopathic dose of paracetamol, 325 milligram, not enough. But then you make the appropriate correction to the paracetamol dose. So 650 milligrams, 6th hourly would be the right thing. Dr. Manisha, I don't understand what you mentioned about too frequent dosing. Yes, paracetamol dose is ideally based on the weight of the person with the illness. Thank you. And what do you feel about gabapentin? For the man that I saw, strangely, he was getting gabapentin, though he could not afford it, but the hospital was giving him free. And I found out this miracle. The hospital did not have tricyclic. Actually, for central neuropathic pains, uh, amitriptyline is the best medicine. But the hospital didn't have it. They don't give it. They give the expensive gabapentin. And why? That may be an interesting question to ask. We may not find the answer very easily. A question. So many friends were suggesting 12 to 15 milligram per kg, 650 milligram 4 times a day. Is there a risk of hepatotoxicity? Manisha, I got your point. Sorry. Well, Dr. Bharat, please make a note of this. In this dose that we recommended, paracetamol is safe. And I have given the reference here. Sri Priya will share this presentation with all of you. You can take a look at this reference also. There is proof that paracetamol is safe, even in chronic liver disease, unless the patient is already in hepatic precoma. And so long as you limit the dose to 2 to 3 grams per day. And if you limit it to 650 milligrams 4 times a day, it is still within this limit. So yes, it can cause hepatotoxicity in large doses, but in the doses that we ordinarily use, it is safe enough, even in presence of a patient in a patient with hepatic cirrhosis. So let us not be too scared of that. The problem is, if in anybody with liver disease, you write a prescription for paracetamol, the treating doctor or a gastroenterologist may get very upset because this is not so widely known. People talk about analgesics very superficially. Gabapentin, yes, it could be used, especially in situations where that's available for free to the patient, but not amitriptyline, but especially in central neuropathic pain. And generally, according to the WHO guidelines of 2019, amitriptyline is a first-line drug. Not everybody will tolerate it, especially the elderly may not tolerate it well. Gabapentin or gabapentinoids like pregabalin, yes, they can be used, I think. But please also remember that the WHO model list of essential medicines rejected it because the companies who manufactured it had submitted fraudulent evidence. This was investigated and found. By no means am I saying that it's a useless medicine. I'm just saying that we can, if we go by published data, maybe we will not use it in every patient. If you find that amitriptyline is not working, then switching over to gabapentin or pregabalin may make sense as a second-line drug. Remember, we are still at the review phase, preparation and review. Now, wait a minute, sorry. We are now planning on to going with the treatment management. Your patient, if he or she is not responding to the dose of morphine that you give, I've deliberately turned off the slide because I want your attention to what I am saying. If the patient is not responding enough to the medicine that you use, Dr. Ruhi and Dr. Jyoti, I'm just randomly picking two names up from the screen that I see in front of you. You are giving morphine, patient is still in pain. Some pain relief, but not adequate. What will you do? You can unmute and speak if you like.
Sir, I would like to go, sir. So we will first check, like you correctly said, we will first check the adherence to the medication
All
dosage that
that,
is
sorry, Rohit, to interrupt, but
okay.
all the measures that I have mentioned so far have been done. Okay,
Okay,
very good. Preparation and review are over.
right. Um, so we would like to try to increase the dose of
Yeah,
morphine or
absolutely,
relook at it.
absolutely. Yes. So thank you. Thank you, Rohit. That's precisely what I said. Why do people then sometimes get delirium? The 25% of patients who I said do not respond well generally end up having neurotoxicity. What does neurotoxicity manifest as? Usually, Dr. Joel, Dr. Noble, random pick. What does neurotoxicity with morphine manifest as?
Restlessness,
Sorry?
restlessness, neurotoxic,
Restlessness, yes.
headache.
No, the headache sometimes morphine can cause
Diagnosis.
headache, but that may not be related to a dose. It's usually if
Confusion and
headache
delirium.
happens, it happens in the early days. Sorry?
So confusion and delirium.
Yeah. Usually the first manifestation is some delirium. It starts as hypoactive delirium, like momentary forgetfulness, going on to overt delirium, person talking in sleep, and it may go on to getting hallucinations also. So these are common. And generally we believe these are caused by metabolites of morphine in genetically predisposed individuals. A good number of us may be generating more of morphine 3-glucuronide. We are not sure that this is the culprit. And if you have a genetic predisposition which releases more of morphine 3-glucuronide, then you may have neurotoxicity in a good number of people. So if you find that your patient falls into this category, you cannot do the enzyme study and all. If your patient is in the category where he or she tolerates 10 milligrams for hourly, you increase it to 15 milligrams for hourly, and the person gets delirious. What will you do? You will have to bring it back to 10 milligrams, right? You can treat delirium with haloperidol, but even then, higher doses may not be tolerated. So you will have to change strategy. So that brings me to the next question. How can we reduce the toxic metabolites? And here we have another question. From oral, if we convert it to intravenous or subcutaneous, may morphine be better tolerated? Sripriya,
Yes, sir. Launching the poll.
the poll is coming up. Please respond. Sri, does everybody know what to do with the poll?
No, sir, I will just brief in case someone doesn't know. So, right after we launch the poll, you will get the question on your screen. what you have to do is you just have to put a response and submit. I'm launching the poll right now. So now everyone can see the question in your screen. So you just have to choose yes or no and submit.
Click on it, you mean? Sri Priya,
Sir?
when you say choose an answer, are you saying click on yes or no?
Correct.
Click on yes.
Yes, sir. Correct. You have to click the option which you feel appropriate.
How many participants are there, Sri?
I'm not able to click it.
Sir, around 70.
Okay. Somebody is not able to click. After the session, will you please talk to Sri Priya and sort it out for the future? Because others are able to do it. Out of 70, only 46 responses yet.
Sir, I guess many are still responding in the chat.
Oh,
Request them to.
okay. At the next poll, everybody, please use the chat poll and click on it. We have 48 responses now. I think I'll move on. The majority says yes. And friends, those who have clicked no. In the case of many medicines, that is true. In the case of paracetamol, that would be true. But in this case, Sri, I am moving on. Okay, with 50 participants, only 50 participants responding. I am very sad. Sometimes in virtual meetings, when response rate is poor, you suspect how many people are actually there on virtually. Okay. What can happen with parental administration is that you can bypass the liver with much of the medicine. When you give it parenterally, the medicine does not have does not have to pass through the stomach. So only a small part of it will reach the liver, and therefore hepatic metabolites are less with injectable medicine. Oh, and here is another poll for you. We switch over from morphine to another. Will that make it better? I'm glad somebody is feeling very happy. Sri, only 3/4 of the people are responding to the poll. So maybe the others are having a problem, not knowing what to do. Maybe that will be worth sending around an inquiry. There will be polls in subsequent sessions also. So please make sure that everybody knows what to do. But this is not bad, much better than previous 83% response. And yes, most of the time, though not invariably, another step 3 opioid may help if morphine is not enough. And that also happens because morphine is the one which creates normorphine, which causes the problem. Methadone and fentanyl are the only other step 3 opioids in India. Methadone is inexpensive. Sri Priya and Sri Devi, am I right in assuming that there will be one session where methadone will be discussed?
Methadone discussed already.
Methadone discussed. Okay, very good. Thank you. So I would encourage you to study it at depth. Using it may not be as simple as using morphine, but to be fair to our patients, 25% of our patients who do not respond to morphine, methadone is a good drug to have.
Sir,
Haji.
sir,
Yes, sir, thus.
sir, I have a small query. Sir, as you have said that switching to opioid free, I mean to say. So how come at least we can observe for around 7 days opioid if
Oh,
we
observe 7 days for what?
for to get the pain relief
With morphine or methadone? What I'm
morphine,
saying.
with morphine, then switch over to can we switch over to the third alternative itself?
And Dr. Das, if I start morphine today,
Yes, sir.
the blood level peaks in 36 hours. So by day after tomorrow, I would know whether that's enough or not. Morphine titration can be done every other day so that the patient does not have to continue in pain. So remember, for morphine, the blood level peaks in 36 hours,
Okay, okay.
roughly. So day after tomorrow.
Yes.
Let us not leave patients in pain. But with methadone, Dr. Das, you are absolutely correct. Methadone takes up to 5 to 7 days
5 to 7 days.
action.
I got confused with methadone, sir.
Yes.
Yes, sir.
I'm glad you asked and clarified it.
Thank you, sir. Thank you, sir.
So, if there is significant neuropathic pain, let us not keep pushing morphine. Neuropathic pains respond only partially to morphine. We may start with amitriptyline, but if necessary, go on to anticonvulsants like carbamazepine or the newer drugs like pregabalin or gabapentin. But if still it's intractable in neuropathic pain, please remember that we can do a trial with intravenous lignocaine. And if the person, of course, intravenous lignocaine, you have to know how to use it. It has to be given very slowly. But if patient responds to IV lignocaine, they may respond well to medicines like flecainide. We had one patient in the last couple of years who would respond only to flecainide and had to be put on long-term flecainide. Ordinarily, it's a drug which is used for cardiac arrhythmias, but in this context, the same principle. By preventing abnormal impulse generation, it can help. Sometimes there can be central sensitization. Does everybody know what central sensitization is? There is a continued barrage of impulses. If pain is left untreated too long and significantly, they sensitize the dorsal horn cell in the spinal cord so that it becomes overactive. Then one impulse going from here will cause 10 impulses to go from here to the brain tomorrow. It will be 100 day after tomorrow. This is what's called the wind up phenomenon, like winding up a spring, making it tight. So in people with prolonged pain, sometimes the reason why morphine does not respond may be because of central sensitization. Does anybody want to type up what medicine you would like to use it there in that situation? Sorry, to go back, I did not see, Dr. Rahul Goyal, I did not see your question. You had asked, if the issue was inadequate response to morphine, will other drugs of the same group help? And the answer, Dr. Rahul, is yes, they may help. The explanation for the adverse effects, patient does not respond to morphine Because when you increase the dose, they are getting neurotoxicity. That neurotoxicity is a specific feature of metabolites of morphine. So with fentanyl or with the methadone, that may not happen. So unlike NSAIDs, if one doesn't work, you don't switch over to another NSAID. That does not make sense. But in the case of step-3 opioids, people who do not respond to morphine may respond to methadone or fentanyl. So as Dr. Bhavika, Dr. Surendra, Dr. Bharat, Dr. Vedavani all said, yes, lidocaine is already over, Dr. Vedavani. That we tried. And now we are suggesting another medicine for central sensitization. Lignocaine, yes, that may quieten the whole nervous system. But specifically for central sensitization, the drug of choice would be a sub-anesthetic dose of ketamine. Ketamine given in a higher dose causes anesthesia because it is an NMDA blocker. We believe that central sensitization is caused by N-methyl D-aspartate. And by blocking it, ketamine may help. It is typically given as a what we call a ketamine burst therapy for about 3 to 5 days. You start with a low dose and gradually build the dose up. When possible, we would use a syringe infusion pump. If not, we may have to give even intermittent injections. You are going to get this presentation anyway, so don't have to bother to write down everything. If you like, when you get it, you can take a printout and keep it. But for countries like ours, naturally, your patient will have to be in an inpatient unit for this. We may not find it always possible. So particularly for our countries, oral ketamine may be adequate. Now, in contrast to morphine, the metabolite may actually be useful here. Oral ketamine passing through the liver, creating more norketamine, which is pharmacologically active, may work even better with a lower dose. So the usual dose that you employ, you start with something like this, which for a 50 kg person will be only 10 milligram, and gradually build up. Again, usually for 3 to 5 days, first therapy. By that time, the dorsal horn cell would have subsided. Sensitization would have been relieved. So that thereafter your morphine may work better or another opioid may work better. So there is some evidence that this has a limited role. It is a limited role in the Western countries because they have very sophisticated other means of treating. In our countries, it's a significant role. The anesthetists in the group may be more familiar with this, but at this dose, for anybody, it would be safe enough to use. Sripriya, here is another poll for the group.
Yes, sir, launching this.
It can be a multi-response. The answer may not be, may be more than one. There are many notas not voting. Okay, friends, the 3 people tiny minority of people who said genitourinary system, you are correct. Those who said liver, you are correct. Those who said cardiovascular system, you are correct. But in this context, with low-dose ketamine, I would be less worried about cardiovascular system. True, it increases the heart rate and BP slightly. No big deal. It's not like an anesthetic dose going in and immediately shooting the blood pressure up. Whereas the others may be greater issues. So, drug-induced liver injury happens. Shall I tell you what we do in Pallium India? If we
Yes.
are giving ketamine infusion, every third day we will do SGPT. We don't do the whole liver function test. Why cost lose a lot of money? Just hepatic enzyme, SGPT, ALT is done every third day. And if it tends to be rising, we stop the ketamine infusion. Continuing it, it may not be wise. If you stop it, then the liver damage is reversible. Secondly, I did say genitourinary system. It's not the kidney, it's the bladder. It
Yes.
seems to cause something like a chemical cystitis. So one thing that we'll monitor every day is to go and ask the patient, is there any burning sensation during micturition? And if they say yes, stop it. Don't continue it, it can be a problem. The microscopy may be clear, there may be no bacteriuria, but chemical cystitis may happen. So these, with the 3 to 5 days of ketamine therapy, unlike in anesthetic practice, these are the bigger issues than the cardiovascular issue, which is a mild elevation of BP and heart rate, if at all. So we have prepared the patient, reviewed the existing medications and emotional status. We have tried a different route for the opioid. We have tried switching to another opioid. We have tried ketamine. With these measures, we hope we'll be able to treat effectively the large majority of patients with long-standing pain. Shall I give you the bad news? Even if you do all that, there may still be 5 to 10% of patients who may not get pain relief adequately, even with all this, especially in non-cancer pains, sometimes in cancer pains also. But then that's true for any clinical situation, isn't it? So if everything fails, this is my final step, step 10. Please remember, don't look defensive. It's okay. You can tell them honestly. I'll never forget Patu, an elderly woman who had such severe pain in the neck from a severe severe cervical spondylosis. And I told Patu, here's what I found. I told Patu, I'm sorry, I have tried everything that I could possibly do. I know I still have not relieved your pain. And Patu immediately grasped my hand in terror and said, don't ask me not to come back here. Even if my pain is not relieved, please allow me to come back and see you now and then, because this is the only place where I get any solace. Nobody else believes me about the pain. So even if our medicines help, remember we have a great role to play. Walking with the people on their journey. I'll repeat that. Even if we fail in symptom control, we still have to walk with that person during that difficult journey. And I have had to do this several times. I'm sorry that so far, okay, not everybody may respond like Patu, or I would say everything that I have tried so far has failed. But if the pain gets worse than now, please come back here. There may be things I can do. If you feel very emotionally distressed, please come back here. Let us talk. I'm not abandoning them. I refuse to abandon them. I'll stop there. I'll keep the presentation here on standby, just in case you all have some questions. Dr. Das, your hand is raised.
Sir, can you speak some more about this one pipe phenomena, one pipe wind up phenomena, sir, regarding
Sorry,
ketamine uses?
Sorry?
Wind up phenomena
Wind up phenomenon. It is not.
and ketamine dose, I need to say.
Okay. I'll explain. Wind up is not only necessarily about ketamine. This is about the pathophysiology of severe pain. Sorry. Let me bring the picture up. Okay. So I said, if this is a peripheral nerve, pain fibers carry pain impulses, electrical impulses to the dorsal horn of the spinal cord, where they get processed for onward transmission to the brain.
Yes.
And with prolonged pain, you can imagine something like a traffic jam. So many impulses are continuing to come from here. And there is sensitization, so that every impulse coming from here sends more and more impulses to the brain. If on the first day, one impulse goes from here, one impulse goes to the brain. Second day, 10 impulses will go to the brain. Third day, 100 impulses may go to the brain. And at this stage, when this has already happened, when it's hypersensitive, like winding up a spring, every impulse lets loose the spring and creates havoc. That's the wind-up phenomenon. And this, I said, was caused by N-methyl D-aspartate. And if you suppress NMDA with a medicine like ketamine, in subanesthetic dose, you may treat the central sensitization. Thereafter, your opioids and other painkillers may be much more effective. The dose for subcutaneous infusion that I mentioned for an adult was 100 to 500 milligrams in 24 hours as a subcutaneous infusion for 3 to 5 days. With a question to the patient every day, do you have burning sensation during micturition?
Yes.
And every third day, a hepatic enzyme study.
Hepatic enzymes.
And if it is oral, the dose is much less,
Right.
0.2 to 0.5 milligram per kg orally, 3 to 4 times a day.
Right. Thank you, sir.
Welcome.
Any other questions?
There have to be questions.
Sir, can I ask you something?
Yes, please.
Sir, about oral ketamine, the oral preparation as such is not available. It is the injectable ones which we are giving orally. Is it that?
Yes. Dr. Manisha, are you an anesthetist?
Yes, sir. I used to.
Okay. Predictably, questions come from anesthetists because others are not familiar with it. Dr. Manisha, thank you for asking the question. Yes, we use the injectable preparation because an oral preparation is not available in India. Ketamine is not pleasant to taste.
Yes.
You will have to mix it
With the
something
sugar.
like some fruit juice or tea or coffee and have it. It can cause vomiting in some people. So if that happens, we will have to continue antiemetics for those 3 to 5 days. I would go for metoclopramide concurrently.
Because we used to give it to children. We had done a study. So we used to mix it with sugar. We used to
Good.
take sugar in a spoon and we used to put ketamine
Mm.
drops on that according to the dose and then
Very good.
give it to the children. So,
Very good.
thank you.
Any other question, ladies and gentlemen?
Sir, metoclopramide is the drug of choice for all nausea and vomiting for palliative care patients who are suffering from morphine-induced nausea, vomiting, or something else also you are using, sir?
For morphine-induced MSs, prophylactically and for treatment, we use metoclopramide, but that's not the only choice. I'll tell you what's not the only choice. I think majority people may be using ondansetron. It is not the first choice for morphine-induced vomiting. Ondansetron is the first choice for chemotherapy-induced vomiting, for radiotherapy vomiting, but not for opioid-induced emesis. You can consider 3 drugs. 1, metoclopramide, given 3 times a day for 3 days. 2, an antipsychotic in small doses, 0.5 milligram of haloperidol, given once a day. 3, phenothiazine, like prochlorperazine or something like that. Your stemetil, for example, which is also given 3 times a day. So these are the choice of antiemetics for morphine-induced emesis, both as prophylaxis and for treatment. I'll repeat, metoclopramide specifically, not every prokinetic. Domperidone may not have the same effect because metoclopramide also has centrally. Metoclopramide, the second, low dose haloperidol, 0.5 milligrams a day, and 3, phenothiazine, like prochlorperazine. Other drugs can be used. I am not saying that ondansetron is ineffective, but it is less effective than these 3, and it is needlessly expensive.
Can we move on to the case presentation for today and take the questions after that? And it's a patient's pain scenario, so I think there will be more questions after that.
Sure, Sri. I think that's a good idea.
Shripriya?
Yes, ma'am. Dr. Ramadevi, you have the option to share the screen because you told that you had made some additions. So
And Sri Devi, will you please go through the chat? I did not. I
Yes,
find
sir.
there
I'm
are some
checking.
questions which
Yes.
we'll tackle at the end.
Sure, sir, sure.
Dr. Ramadevi, can you please try sharing the screen from your end?
Yeah, good evening all. I couldn't able to see the option.
We have already enabled it, ma'am. So otherwise, you can just WhatsApp it across to me. I'll share.
So during that time, probably I can ask 1 or 2 questions in the chat, which came a little earlier. That when a patient of yours is asking whether they can go for Ayush treatment in certain pain, what should be your reply?
The question is radio frequency ablation?
No, sir. Patients want to go for Ayush system, alternative medicine.
Okay. Thank you for asking the question. A lot of patients of ours are concurrently taking Ayurvedic or homeo medicines, commonest. So they ask me, can we take this? And I'll honestly tell them, I know very little about those medicines. Please talk to your Ayurvedic physicians. But of my medicines, this and this, I think you absolutely need. Please go and ask them, can you continue the morphine while taking the other medicine? and I'll leave it to them. Sri, there is some other question. I think I saw something else.
There was one question on anti-epileptics in
Uh-huh.
pain, which was, I thought, is covered during adjuvants. But sir, if you have a, because it's a long question, what are the indications and which are the preferred drugs? So that's
So, doctor, anticonvulsants, anti-epileptics do act in neuropathic pain by causing membrane stabilization, by preventing abnormal impulse generation from the nervous system. And they may be effective in neuropathic pain. So, depending on the nature of the neuropathic pain, sometimes along with opioids may be partially effective. You may start with either a tricyclic or an anticonvulsant. But there are some situations, I have not gone into the details there, something like post-herpetic neuralgia or a central neuropathic pain, as happened to my patient whom I saw today. That situation, tricyclics seem to work better. But something else, say for example, trigeminal neuralgia, generally anticonvulsants work better. So sometimes a combination of both also may help. So you will start with tricyclics for some, anti-epileptics for some, and may even combine both of them. Both of them together can cause significant tiredness and sedation. So the dose will have to be carefully titrated up.
I think Shripriya is ready with the presentation. Dr. Ramadevi.
Good.
Good evening, one and all. I'm Dr. Rama Devi, Senior Resident of Medical Oncology. Am I audible?
Where, doctor?
Yes.
Rama, where are you? Which institution?
Bangalore, Ramaya Medical College, sir.
Okay, Rama.
In our hospital, I came across one case which we find difficult to manage her pain. She's a 37 years old female who is a diagnosed case of metastatic carcinoma rectum with nodal and lung mets. She already received first line of palliative chemotherapy with Folfox and bevacizumab. Can you change the slide? Now she presented with the complaints of perianal.
Dr. Rama, I think she lost the connection suddenly.
Sri Priya, can you show the previous slide once more? If you are operating it. See rectum. Down. Next one. Perianal pain. So while we are waiting for Rama to reappear, perianal pain associated with difficulty in sitting position. Sridevi, we have got a very good example of difficult pain. Oh, nasty thing to have. Severe pain in the left lumbar region. Left lumbar region extending to left hip. Constipation, fatigue, reduced appetite since 15 days. Rama, are you back? Sri Priya, can you show me the next slide, please?
I'll just read out this
Back,
slide.
sir, but her device audio is not enabled. That is
Okay.
why she is not able to communicate with us. Maybe she will have to log out and then log in again.
Okay, we'll go on to the next slide for on behalf of Rama. Metastatic carcinoma
Lower
rectum.
rectum stage 4. She received palliative chemotherapy with Folfox plus bevacizumab. In view of progressive disease, the patient was started on second-line systemic therapy since 1 month. I think Dr. Rama is back. Can you please?
In elaboration of this, her present complaint, she presented with the complaints of both anal pain and the back pain, which is continuous, dull aching and shooting type of pain, radiating to the left hip region, and which is more during the night times, and she is not getting any relief on the any pain medication, aggravated by the walking and prolonged sitting position, and the pain is so severe that making her to bedbound with a disturbed sleep. Based on the pain scale, she falls under like a very severe pain of 7 to 9 score. And she has another complaint of constipation since 15 days, passing hard stools once in 2 to 3 days, associated with the severe pain and intermittent bleeding PR, and not relieved by laxative usage. And there is associated reduced appetite and the sleep due to the pain. Coming to the examination, general physical examination is normal. She's conscious and oriented, and the vitals are stable. And her performance score on ECOG scale is 2 because of the pain, which is restricted her physical activity. And the systemic examination of cardiac, respiratory, and CNS is normal, and there is no focal neurological deficits, and the straight leg raising test is negative. And per abdomen showing the tenderness in the left iliac fossa and the left sacroiliac joint. And routine investigations were done. Her biochemical and hematological parameters are within normal limits with a slight hyponatremia of 129. And chest x-ray showed bilateral lung mets, and x-ray pelvis showed no significant abnormality or the fractures. So this is a pain medication we have given to her during an OPD basis. She was initially advised with the tramadol 50 mg 3 times a day, along with the paracetamol 650 mg 4 times a day for 5 days. Since she didn't get any pain relief with those medication, we shifted or upgraded to Buvilar patch 10 mcg per hour. Even after applying the Buvilar patch for 4 days, along with the paracetamol, she didn't get any pain relief with that. So we took the pain clinic reference, and she underwent diagnostic impure ganglion block to see whether she will get benefit or not. But there is no pain relief after the 48 hours of the block. Finally, she was started on morphine tablet 10 mg per oral 4 times a day for 5 days. She told like the pain reduction is only by the 20%. However, the patient is not taking properly, and she is complaining of because of nausea and dizziness. She is skipping the doses in between. Coming to the psychosocial aspects of this patient, she is a very young 37 years old female with a one child, came from a high socioeconomic status with the complaints of severe pain in the abdomen and the hip region, which is unbearable, and severe constipation, and she is not able to perform her daily activities and spending time with the children, and the financial burden for the treatment because of the
I think we lost Dr. Rama again.
Maybe we can go to the next slide. So the main concern was, are you back? Okay.
So the main concerns regarding this patient is, one is refractory pain after like so many pain medications, and simultaneously there is a progressive disease on the background of it, and there is a loss of personal and the family life. After summarizing this case, this 37 years old female who is diagnosed case of metastatic CA rectum stage 4 on the second line palliative chemotherapy for the progressive disease, presented with the perianal pain, which is refractory to the step 4 pain management. So discussion points, do we need to provide palliative care for this patient? What are the problems faced by this patient? And what all can be done for this patient for the pain relief?
Rama, let us leave the questions there. Rama, thank you.
Yes.
Rama, I am particularly happy when I see oncologists doing palliative care course, because I know that like everybody else, I have a 10% chance of dying with cancer. And then to answer your first question, absolutely. I need palliative care from the time I start having my symptoms, even before you start your treatment. And somebody like you, combining oncology with palliative care is what I need.
Yes.
Would everybody disagree? Absolutely. Not only now because of the pain, but from the word go, when you are telling me that your report has come, you have cancer, From that time, I want your palliative care approach. The most important problem, Rama, is the patient still with you?
Yes, sir, still with us.
Let me give you some good news. I think we have an excellent possibility of relieving this hapless person's pain. Maybe, I'm sorry, maybe our treatment is worsening the pain. The culprit most probably, okay, the person has a CA rectum. Very likely there is a neural infiltration or a neural compression.
Yes.
But the main culprit here could well be the constipation. Constipation means greater pressure on the nerves and absolute misery. The suffering is more from the pain. Your laxatives have not helped.
Yes.
You have tried buprenorphine, which is a medicine between step 2 and step 3 of the ladder. Is significantly expensive. You have tried laxatives. They don't seem to work. So Surender says relieving constipation can help. But Surender, please solve the problem. Rama has already given laxatives. What are you going to do? Rama, this person is likely to have hard fecal matter high up. So what I would request your nurse to do is to do a rectal, or what I would request you to do is do a rectal examination, and sometimes just evacuating the rectum of impacted fecal matter digitally may solve part of the problem, but not fully. Now there is long-standing constipation. Ordinary enema may not work. With this length of constipation, I'm sure you have tried laxatives. Suppository may work, may not. Enema may work, may not. But what I would request the nurse to do is to pass a catheter up the rectum, a high enema, a large bore catheter, passed as not too soft, passed as high up as possible, and then give a double enema. If you are using practicals, use 2. So this process may have to be repeated for 2 or 3 days. I think all your medicines may be more effective when the constipation has been relieved. This is perhaps a bit classic thing to find. And then you may find that your ganglion imbar injection works. You may find that your opioids work. Dr. Hedel is asking role for Ayurvedic medication. In a unit where I worked, once we studied a comparison of our bisacodyl. Kalyanji, can you mute you? Okay. So we tried. We know they are effective, but I have not found something so superior that will treat an obstinate constipation like that. Even castor oil, drastic purgative, once the impacted fecal matter is there, may not be effective. Manual removal, as Dr. Surender says, initially followed by high enema. A lumbar sympathetic block, Dr. Saida, may be very good for an upper abdominal malignancy and pain, but not so effective as for a rectal pain. An superior hypogastric plexus block may work, but then neurolysis there is not very effective. Dr. Preetak, fentanyl also will cause constipation. And look at the patient's financial status before you try it. Fentanyl is less constipating than morphine, but still constipating. I think the answer is to treat the constipation effectively and aggressively and then you continue morphine, if at all possible. And if the person is rich, switching to fentanyl may be a possibility.
So
Sri,
just
anything you want to add?
Yeah, so just regarding the fentanyl question, I mean, once you have a pain which is not stabilized, fentanyl patch would take at least 10 hours to start acting. And then again, you won't be able to increase the dose as you do with morphine. You have to remove the patch or you have to add one more patch, which will again take another 8 to 10 hours. Even if you remove the patch, that will be there in the bloodstream few hours. So that titration won't be easy until and unless your pain is stabilized with oral preparation like morphine. So once you, as sir told, once you relieve the constipation and then once you get a optimum dose of morphine, and if the patient can afford, definitely can think of fentanyl. But unstable pain, it will be difficult to manage with fentanyl in the beginning. Any other questions? Dr. Bharat has written about high fiber diet, and I've seen another question on sleep medicines, sir. That came first. That can we give sleep medicines for pain relief?
Let me try to answer that. If you want to insist on an answer in one word, I would say no. When there is significant pain, giving sleep medicines make the person sleepy, still unable to sleep. They may actually feel more miserable. You have to relieve the pain first. Dr. Bharat Singh, a high fiber diet is good as a precaution, but once constipation has set in, it may not be a great idea. Okay, a patient can take high fiber diet as you treat the constipation, because what does it do? It increases the bulk of the motion. And if fecal matter is impacted and not moving, you are actually worsening it by giving high fiber diet. So I'm not saying no to high fiber diet, but in somebody with opioid-induced constipation or something related to erectile malignancy, that may not be effective at all.
So there is another question. I'm not sure about that drug, lubiprostone.
Doctor, you want to say what that is so that everybody understands what it is?
Which class of drug lubiprostone is?
The problem with lubiprostone mainly is that it is very expensive, if I am not mistaken. Doctor, is that correct?
Yes, he said it is
Lubiprostone, as far as I remember, is a stimulant laxative which increases the motility of the intestines and the sacs. I thought it was something that is what we would call a mild stimulant, not a bisacodyl or Sena, I would say, are strong stimulants. This becomes particularly useful in patients with irritable bowel syndrome by softening to stool. But in something like this obstipation or obstinate constipation as caused by the combination of rectal malignancy with opioids, I don't think it will be better than our ordinary stimulant laxative. But personally, I have no experience with it. What I am saying is only theoretical. Maybe if you yourself know more, please tell us.
While Dr. Pugarendan is typing, there was a previous question on whether SNRIs or TPAs for neuropathic pain.
For neuropathic pain,
Yes.
ordinarily, SNRIs are not recommended because tricyclics are superior in this context. Otherwise, for depression, you consider tricyclists as a last thing nowadays. But how do they act? They act by membrane, action on the descending pathways. And they are not specific. The non-specificity is actually an advantage. So generally in neuropathic pain, unlike in treatment of depression, SNRIs and SSRIs are inferior to old tricyclic antidepressants. Not saying that they cannot be used. Maybe in somebody who doesn't tolerate a tricyclic, if I try, say for example, suppose we are talking about a patient with post-herpetic neuralgia, where anticonvulsants may not be optimally effective. They are not tolerating a tricyclic at all. I might try an SNRI, but not otherwise.
Sir, there's a question.
Duloxetine, Dr. Bharat also asked about duloxetine. Dr. Bharat, the duloxetine is not a first-line drug for neuropathic pain. It is again another antidepressant. Duloxetine is a second-line drug, particularly of greater value in diabetic neuropathy. We have not gone to specificities like that. In diabetic neuropathy, the problem also is that because of the autonomic implication, tricyclics may not be tolerated much. So duloxetine, ordinarily a second-line neuropathic medicine, could be the first-line medicine, neuropathic medicine in diabetic neuropathy. Can be effective, but not only when the first-line drugs are not effective, except in diabetic neuropathy.
So Dr. Suhaila is asking, considering this patient has CA rectum, will all the rectal measures, can it cause bleeding, whether it is PR or digital evacuation?
Yeah, the answer is yes. Dr. Emma, can you please come back? Where exactly is the tumor? Is it such that digital rectal examination and digital evacuation
It's a
may cause bleeding? Thank you for the question. Very important. Being a non-oncologist, I did not think of that. Thank you for bringing up the point. Now, before my answers, my only point is, even if that's a possibility, in this case, emptying the bowels is life-saving. She cannot continue to live with that chronic constipation. So that may be a calculated risk that you take. But Dr. Emma, please tell us, is the position of the tumor such that a digital examination or a high enema may be very dangerous? Is there a history of bleeding?
Patient is actually having that bleeding PR intermittent episodes, sir. Already patient is having that bleeding PR episodes, and radiological wise that growth is involving the proximal and the mid rectum.
So you think a rectal examination may still be possible?
Yes, sir, it's possible.
So, so the other question, in this case, concerning that evacuating the bowels can be a life-saving process, I would risk a well-lubricated catheter being pushed as far as possible. Lemma has a very difficult situation on hand. Lemma, one lesson to take home from this is, in your practice, in future, aggressively prevent and treat constipation. It shouldn't happen. As soon as we get the person, be very conscious about this, especially in these patients who come and say they have diarrhea, which may be actually overflow incontinence in impacted feces. So that is a prophylactic measure that we have to consider. This patient cannot possibly survive without evacuating the bowels. Remember, constipation can kill.
Any other questions?
Sri, thank you. I must thank all the participants, particularly those who interacted, asking the questions and offering suggestions. Thank you all very much. That was very nice of you. I'm still a bit worried about the 25% of participants who did not participate in the polls. 25 people, 25% is a large percentage. What is Etisha? Etisha, Sri?
Sorry, it was Dr. Etisha asked a question whether the constipation can be due to the growth and the obstruction. So I was just telling it can be due to the obstruction and it can be opioid induced because she was on tramadol and buprenorphine in the past also. Tramadol, although we see people don't prescribe laxatives very well with tramadol. Tramadol is also very constipating.
So Rama, please, you know more about this than I. Please correct me if I'm wrong. In rectal malignancy, if, of course, as Sri said, before we are using opioids, we have to aggressively use laxatives. But in addition, if it is already causing some degree of obstruction, corticosteroid along with the laxatives may be necessary just to reduce the peritumor edema and allow the fecal matter to pass through. Dr. Rahul's question, Sri, did you see? The patient has tumor localized to proximal rectum. Then there are two issues. Why perianal pain? Do we need to rule out any local abscess as she has difficulty in walking? Rama, this is taking it beyond me. I don't know whether that kind of abscess is common in that situation. But persistent pain can be because the neural involvement.
Yes, sir. That patient, like local examination, we couldn't able to find any local abscesses or like infection.
Okay. Thank you. And Manisha's question, she's not taking morphine due to side effects. They did go for other opioid, Manisha. They went for buprenorphine and it did not help adequately.
Thank you. Thank you, sir. Thank you all the participants for asking and interacting with a lot of questions and answers. So that's always a great learning for us sitting here also. And I hope Dr. Rama will look into the constipation part and let us know how it went. So even after the session, if you have any queries regarding the patient, you can always contact us through the WhatsApp group. We'll be able to help you. We also have a telehealth line where one doctor will be and the nurse will be there full time. So professionals can also contact them if you are stuck with managing any patients. It works from 9 to 5. That number also I can share in the WhatsApp group. So the discussion need not be stopped with this session. If you go back and try to implement what we have discussed, and if you find any questions at that time, kindly contact our telehealth or even just let me know in the WhatsApp group. I'll connect you to the team. Whichever I can answer, or Dr. Sunil, we will be able to help you through the WhatsApp group. Thank you so much, sir, for sharing your experience in managing difficult pain. Every session, I also learn a lot, even after 11 years. So it's always a learning from all the participants and me. Thank you so much.
Thank you so much,
Thank
sir, for
everybody.
joining
Thank-
us. We understand that it is a day of celebration all across India, and hopefully you also might be having guests over at home. Still, you found out time on this wonderful evening to enlighten us with your knowledge. Thank you so much for that. Thank you, each and every participant, for making this session interactive and lively. So, with the hope that we'll be meeting again in the next session with another important topic and yet another eminent faculty. This is Sri Priya, along with Dr. M. Rajagopal and Dr. Sridevi Warrior, signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Keep spreading happiness. Bye bye.